there, my name is Aaron Silver. I'm a MedPeds trained general medicine ultrasound fellow at Oregon Health and Sciences University. And today we are going to spotlight lung ultrasound, one of my favorite exams for the pediatric hospitalist. And I have nothing to disclose. Today we'll be talking about indications and advantages of lung ultrasound. We'll identify your probe choice. We'll talk a little bit about thoracic anatomy. We'll demonstrate the exam steps. We're going to differentiate some pathology from normal findings. We'll talk about some pearls and pitfalls, and of course, bring it home with a nice case. So first, why lung ultrasound? So I think there are a lot of reasons, in particular in pediatrics. So lung ultrasound has the potential to decrease the number of chest x-rays that we ordered. Of course, in our pediatric population, they are more susceptible to the effects of radiation than adults. And kids have smaller thoracic cavities, so ultrasound can actually give us even more information than it can in adults generally. And one thing I really like to talk about is that it's ours. Lung ultrasound doesn't belong to anybody. And this is just information that is free to obtain. We can get it pretty easily right at the bedside, pretty quickly. It helps to build rapport with our patient, and I find that kids don't get so worried about it. It actually ends up being a nice experience with your patients. So, lung ultrasound is very useful in neonatal lung assessment. It's very helpful in detecting and ruling out pneumothorax. It's useful for bacterial and viral pneumonia, complications of pneumonia, and identifying pleural effusions. The operating characteristics are fantastic, especially for the bottom four, where the sensitivity and specificity are in the 90s. So as you're approaching a patient, it's important to select the correct probe. For smaller kids, I use the high frequency linear probe because you can get a lot of detail about the pleura. And because they're small, you can actually get some deeper parenchymal information as well. Larger kids, I'm using the curvilinear probe. Generally, we're using either the lung or abdominal preset. If your machine does not have that, sometimes I will use the vascular setting to evaluate the pleural line. Now that you have the right probe selected, it's important to get a good full exam of each lung. So here's one example of just one of many lung ultrasound protocols, but this is one where we look at 6 different fields on each side of the chest. So 1, 2, 3, and 4. 1 and 2 are anterior, 3, 4 are lateral, 5 and 6 are posterior. For each of these lung fields, I have my probe marker facing towards the patient's head, and that's very important. And that will create an image like we have here, where these 2 round circles, these represent ribs. Those cast a shadow that is represented by these large dark triangles, and the thicker black line represents the pleural line. So your eyes should go to that as being the layer that's just deep to the ribs. So within each of those locations, you're going to be performing these steps for evaluating the lungs. First, you need to make sure you center the pleural line, and you need to make sure that the probe is exactly perpendicular to the thorax. And that is how we optimize some of the artifacts that are required for this lung ultrasound, and we'll talk about that more further. Then we take an outside-in approach where we evaluate the pleura for sliding, thickening, or any local consolidations. We'll look at the artifactual pattern A lines and B lines. We'll talk about that shortly. And then in the basilar areas, we're going to look for a pleural effusion. So this is how we perform steps 1 and 2. And this is an example scan where I'm first putting the probe on the patient and identifying the relevant anatomy. So you have both ribs here, which are casting the shadow, and then you can use those as a landmark to identify your pleural line, because that will be the line that is just deep to those ribs. But to really optimize your image, you need to make sure you are centering that pleural line and then rocking to make it flat, and then fanning so that you are exactly perpendicular. And that's exactly what I'm doing in this image. Notice how it starts off as kind of a washed out image, where you're not really seeing a lot of detail that's deep to the pleural line, and then you get these nice crisp horizontal lines. That is exactly what you want. Now that you've centered the pleural line, we're ready to start analyzing it. So here's a healthy example first. You see that arrow is pointing right to the pleural line. Take a close look at it. Notice it's kind of shimmering a little bit. You can almost imagine little ants crawling on a log, just like right on top of that pleural line. that is healthy. That means there's a healthy interface between the visceral and parietal pleura just sliding nicely on each other. So get really used to looking at that image because that's what you'll typically see. And we will show you an abnormal in a minute. But if you really want to confirm to yourself that there is movement there, you can utilize something called M mode or motion mode. And here's an example of that where we've put M mode through that very same image. And it creates this sort of picture where we see no movement above the pleural line, and then we see this static appearance, almost like a sandy appearance below the pleural line. So we call that the seashore sign, and that's very reassuring for healthy lung where there's normal lung sliding. Here's an example of the absence of lung sliding. So if you look, this image on the left here, you look at that pleural line, it's really not moving very much, right? With each breath, the chest is moving slightly, but that line is really not shimmering. And here's the M mode confirmatory image. And see how it just straight lines all the way across as opposed to that nice sandy beach or seashore sign? So this is called the barcode sign. And this is confirmatory for the absence of lung sliding. And here's your normal example for comparison on the right. Now, there are a lot of reasons why you can not have lung sliding. So one, and most concerning, and you would want to take this in clinical context, is that you have a pneumothorax. So there's air between the visceral and parietal pleura, so we're not getting that nice sliding appearance. But it can also happen when that area of the lung is not participating in ventilation. So in kids, we can see this when there's a foreign body aspiration that's causing significant obstruction. We can see this in cysts or blebs in the lung, or we can see this when we have surgically fused the visceral and parietal pleura, like in a pleurodesis. Once you evaluate it for sliding, you can look for other things like subpleural consolidations or irregularity. So here's an example. This is actually an embolus. This is septic from a patient with endocarditis. And we see this interruption of the pleural line, and we get this differentiation of tissue. This is somewhat of a shred sign, we call this, where it kind of wraps around, where you have this hypoechoic or darker collection that's near the pleura. And then deep to that, we see these vertical projections that are similar to B lines, which we'll talk about shortly. Here's another example where we just see this little area of darkness and irregularity under the pleural line. And here's one in a child with bronchiolitis where we see this diffuse appearance of irregularity where the entire pleural line looks nodular and really not healthy appearing. When those subpleural consolidations coalesce or become even bigger, we'll get findings like this. This is just some really gnarly lung here. We're finding a few things. For one, we can actually see lung tissue, which is unusual because there should be air there, which makes it difficult for us to see. We call this tissue sign or hepatization because it looks similar to the liver in texture. We're also seeing these little bubbles that are sliding back and forth. This is called a dynamic air bronchogram. And we're also seeing something called shred sign, which is where this consolidation ends and then some aerated lung begins, just at the deepest part of the image here. All of these findings are very specific for bacterial pneumonia. All right, so we've evaluated the pleura. Let's talk about the pattern now. And I find that for early learners, this seems to be the most complicated and difficult to understand. So let me break it down for you. The pattern of lung artifacts is very important. So remember, the lung is filled with air, and air is the enemy of ultrasound. So ultrasound waves really are just going to bounce off air-filled structures. So in normal lung, we're going to see a sliding lung like we've talked about already, but we're also going to see these horizontal lines, and these are called A lines. And really what that represents is the bouncing back and forth of the ultrasound waves between the skin and the pleural surface. And they bounce back and forth to create these lines. Now, the machine doesn't understand where all the ultrasound waves are coming from. It just knows that some of those waves took longer to come back to the machine. So it projects these horizontal lines into the lung parenchyma. And this image indicates air-filled lung. Now, let's contrast that with B lines. So B lines represent some change in air to fluid index within the lung. So instead of being completely air-filled, there's some fluid in the lung. So that could happen in an infection, it could happen in pulmonary edema. And those ultrasound waves are actually able to penetrate between some of the alveolar septa and bounce back and forth between these air-filled structures, and you get this vertical projection from this pleural line. Now, keep in mind, one or two B lines, that is not really concerning because we can have a little bit of fluid within the fissures, but greater than 3 in any space is concerning for some degree of pathology. If we see B lines everywhere, that's concerning for diffuse alveolar syndrome, alveolar interstitial syndrome. If we see it in one single place, that's more concerning for a focal process like a consolidation or pneumonia. The last step of the lung ultrasound is looking for pleural effusion. So in this case, we are putting the probe in the mid to posterior axillary line, right at where we think the diaphragm is. So that generally we're going to see an interface between the lung, diaphragm, and then liver on the right, or spleen on the left. And this is what we get. So this is a typical image of a normal healthy lung with no pleural effusion. So we are seeing the liver, we're seeing the lung slide over the liver with each breath. That's just because the diaphragm is coming down. And notice it kind of looks like a curtain. So that's called the curtain sign. And that is a good sign that there's likely no pleural effusion. Let's contrast that with a very large pleural effusion here, where we're seeing all this dark fluid, it's anechoic, and that allows us to illuminate the spine. So compare the two images, we can see the spine very clearly on the right, and we really can't see it above the diaphragm in the left. We call that positive spine sign, and that is very sensitive for a pleural effusion. Now, we are excellent at this in ultrasound. We can detect about 20 milliliters of fluid. Compare that to a chest x-ray, which is closer to 150. So in addition, we can also describe the fluid a little bit more. Are there septations? Is there some material in there that's concerning? And this helps us to evaluate whether it can be drained or not. Concluding the lung exam portion, here are some pearls and pitfalls. First, remember, exam technique is very important. You must make sure you are perpendicular to the chest wall to get a good image and make sure you bring out those artifacts. Secondly, sometimes we miss deeper parenchymal disease. So some consolidations are hiding, some are hiding behind the heart, and some are not in contact with the pleura. Remember, we're only going to see what is touching the pleura. We won't be able to see around any air that is between our probe and whatever process is happening, like consolidation. However, in general, point-of-care ultrasound is better than chest x-ray for detecting pneumonia, pneumothorax, pulmonary edema, and pleural effusions. So hopefully this will allow us to start limiting chest x-rays in the future. Let's close with a quick case courtesy of Dr. Bryson Hicks, who's our Emergency Medicine Ultrasound Fellowship Director at OHSU. We have a 6-year-old with 2 weeks of cough, a little bit of fever, and some shortness of breath. He's coming in febrile, and he's got some decreased air sounds in the right lower lobe. Differential at this point was pneumonia, COVID, atelectasis, maybe pleural effusion. And here's what the ultrasound showed. So think back to what we just talked about. What are we seeing here? We are seeing sliding lung, and we are seeing A-lines. So that's reassuring for at least that area of the lung being normal. What about here? So now we're looking at the right lung base, which is the area where there was some concern. So we are actually seeing this is all consolidated lung here. And see these little bright spots? This is air. So these are air bronchograms, and we call these dynamic air bronchograms because they are moving within the tissue. This is highly suggestive of bacterial pneumonia. Now here was the corresponding chest x-ray, which was actually much more equivocal. So the chest x-ray was not able to distinguish between atelectasis and pneumonia. But because we had the ultrasound and we saw those dynamic air bronchograms, we were very concerned for bacterial pneumonia. Ultimately, the patient was treated with antibiotics and he improved. So here are some of my references for this presentation. Okay, I'll leave you with some take-home points here. First, remember, exam technique is very important. Make sure you are perpendicular to the thorax before you're making any assessments. Lung ultrasound performs better than chest x-ray for most of our common indications. A is for air, B is for bad, so A lines and B lines. And lastly, let's see if we can start limiting chest x-rays that are unnecessary, especially when we can get the information without radiation. Thank you so much. Here's a little bit about me, and I hope you have a wonderful day.